Welcome to our first session in the RIC Learning Week. It's great to see you all bright and early. Lots of you have already put your names and organisation in the chat, so do continue to do that. I'll just go through a bit of housekeeping, a bit of an introduction, and then I'll hand over to Dr. Sohail. So yeah, if you can put yourself on mute, looks like most people have. Or maybe there's one or two people that haven't, but if you can just do that as you come in. As mentioned, there's going to be some time at the end to ask questions for the speakers. So while they're talking, if you want to just pop them in the chat and we'll pick those up. We might not get a chance to answer them all, but we can certainly see what the questions are and we can get back to you outside of the event if we don't get to cover them all. So just have a think about what you might want to ask, and you can just put your hand up at the end and we can ask the speakers. If you want, you can tweet along while we're having the session this morning. Our hashtag is Reducing Inequalities BDC, which I'll put in the chat. And today's session is Reducing Inequalities in Communities. What is it and what did we learn? So it's the first one in the series of sessions this week. So the theme of this session is to share the impact of our work from the RIC programme. So the RIC programme is, I'll just give a little bit of an introduction in a second, and then Sohail will talk a little bit more about it. But we want to share not just from a population perspective, but also how this programme has influenced how we try and tackle inequalities from a system perspective. So we've got Dr Sohail Abbas, who's joining us today, and also Sasha Bat, and they have both been involved in the programme from the beginning. So just a bit of an introduction for the Reducing Inequalities in Communities programme, because I know some people on the call today might have heard of it but not really know what it is. Some people will be very familiar with it, and I know there's some colleagues on the call that have been really part of the session of the programme. But basically, we know, and I'm sure many of you do, that in Bradford District in Craven, there's significant health inequalities in our communities, and the gap in how long people live is really stark. We know that people that are living in the more deprived areas of the district are living with more ill health and dying earlier. So in the most deprived areas, for example, there's a difference in life expectancy of 10 years. And the difference in healthy life expectancy, which is how long someone lives in good health, is 20 years. So that stark inequality was why the Reducing Inequalities, or RIC programme, which is what we call it for short, was set up. And it was set up back in 2019 as part of a 5-year programme to test out all these various interventions. So lots of different projects. There was 21 different projects in total, all tackling different areas of inequalities in a person's life stage, so from birth through to end of life. And we worked with lots of different partners on this, so it wasn't just the NHS, it was VCS colleagues, it was the council, lots of different partners. So this RIC Learning Week is highlighting learning from the past 5 years, because it was always a 5-year funding pot, a bit of a test bed. And we wanted to see what works and what doesn't work. So if you want to find out a little bit more about the background of the RIC programme, I'll post a link in the chat, and that's got a video that we did when we first started, and it just gives a bit of an overview for you. So you can watch that in your own time. So I'll post that in the chat. But I think that's enough from me. Sohail's going to talk a little bit more about this. And I'll hand over to Sohail. Sohail, do you want to introduce yourself? You'll probably do a better job than me, and I'll hand over to yourself.
You've done fantastic. Thank you very much, Sophie. So I'm Dr. Sohail Abbas. I'm a GP partner in Inner City Bradford, Director of Population Health and Inequalities, and I'm also Deputy Medical Director for NHS West Yorkshire. I was the chair of Bradford City Clinical Commissioning Group when we started working on this program. And as Sophie said, I've been involved in this since its inception as an idea in the city CCD. And it just feels like yesterday when we were thinking, we were brainstorming in the clinical commissioning group what to do with the in the uplift from the NHS England. What can we do to do something tangible for the health inequalities for the people living in inner city Bradford? And five years have passed. And now looking back, we have achieved a lot. We have done a lot. We have learned a lot. And as Sophie said, this week is going to be sharing that learning. And there will be a detailed report as well that will be published in March describing the learning from all the projects. So I do have a few things to say about something that has been and is very close to my heart, the RIC program. So Reducing Inequalities in Communities, that is commonly known as RIC. It has been the flagship program of health inequalities in inner city Bradford area of Bradford District and Craven. And it has really allowed us to develop and learn from our local approach to tackling health inequalities in the most deprived areas. So it was formed, as Sophie said, from an increased funding in 2019 from NHS England to tackle the stark inequalities and poor life expectancy in inner city Bradford. And the funding came from the recognition that health inequalities for much of the population of England are really deep and entrenched, and that existing ways of delivering services were not having the desired impact. So it recognized that equal was not fair. And to improve outcomes for some of our most deprived communities, we needed and we continue to need to embed the principle of equity and proportionate universalism, as we call it, rather than equality, to our service planning and delivery. And this principle to provide additional capacity and resources to facilitate equal access and outcomes, it underpinned the prioritization of the RIC projects. And our work follows our partnerships act as one ethos and the vision of helping people to live happy, healthy at home. So over the years, since RIC program was launched in 2020, more than 50 partner organizations have worked together as part of a collaborative to initiate and deliver 21 different projects. The projects reached a significant number of people, with over 16,000 people of inner city Bradford benefiting directly from the RIC program. That includes service users, new volunteers that this program trained, and people working across our place who have received training and upskilling. And the projects have employed around 100 whole-time equivalent staff, most of which are in completely new roles. And this program has instigated new and collaborative ways of working to tackle health inequalities. The decision to ring-fence the additional funding for health inequalities and the creation of a distinct program of work created clear focus and intent on improving outcomes for the people of Central Bradford. Creating RIC as a standalone health inequalities program allowed for better collaboration between system partners through the different projects, and we had a common goal for organizations to work together to achieve. In this program, we adopted a population health management approach. We used data and local knowledge to develop intelligence about our population needs, identified population segments at risk of ill health, and co-developed interventions with our statutory and community provider colleagues to manage those conditions. Having a framework for prioritization, which was co-produced by public health and our research colleagues, it provided real rigor to decision-making, particularly when combined with the Delphi prioritization process. You will hear more about this process. I think it's the end session, isn't it? The last session of the RIC program, where Inequalities Research Unit colleagues are providing their insight. That all provided a clear rationale for how decisions were taken and the recommendations were reached. And having a combination of intervention types that included testing new approaches, as well as building on previous successes and expanding previous work. Doula, for example, that's an example of the work that was already going, and the RIC program really expanded that. It meant that we have been able to gain momentum in certain areas quickly, as we didn't have to create new infrastructure and the skill sets. As Sophie said, working with the voluntary and community sector organization, that has been a distinct feature of all the RIC projects. And what we have done is the VCSC colleagues as part of the pathway of care, that has been a really distinct feature. And also highlighting human stories and sharing learning across projects has been effective, really effective, and contribute to the RIC story. Showing the real impact for individual lives, that helps to show the real value of the work the projects are achieving to reduce health inequalities. In the RIC program, we brought together two distinct worlds that traditionally do not work together. They just work in silos, the world of commissioning and the world of academic research. We developed the Bradford Inequalities Research Unit. The academic expertise and access to big data brought a unique element to the RIC program, providing the opportunity to deliver the most relevant, feasible, and evidence-informed interventions to reduce health inequalities. As a result of this, Bradford District and Craven is seen regionally and nationally as an exemplar in its leadership approach to tackling health inequalities, and Dr. Bola Awolabi, Director of the National Healthcare Inequalities Improvement Program at NHS England, she came to Bradford to visit our projects, and she has been a real ambassador of the RIC program at national level. So there are elements of the RIC program success that are evident now with the evaluation done by the Inequalities Research Unit. There will be a lot more in the report when we publish. But there are also elements of RIC whose impact will not be seen for years. And that is the reality of the program, of the work, working on the health inequalities. So we have learned in RIC that greater consideration of the wider economic benefits of a program should be undertaken at the start of the program. And that should include things like employment and positive impacts on the criminal justice system, as well as the impact that a service has on the wider family and community of an individual. And this is a learning that we shall incorporate in future programs of population health and inequalities, and look at the wider health economics to show benefit realization. I would really like to take this opportunity to thank each one of my colleagues. There are so many, I can't really start naming all of them, and you know who you are. So all of my colleagues for their support, passion, enthusiasm, sincerity, expertise, and hard work. It is a testament to the dedication of all the people involved in delivering the RIC program that we fully mobilized 21 projects in an unprecedented set of delivery challenges triggered by the COVID-19 pandemic and the subsequent financial and wider workforce pressures. Despite these challenges, RIC projects have shown significant impact on health inequalities, and you will hear from the project leads later and the details in the report in March. So whilst the RIC as a standalone program is reaching its end, we are living in the post-COVID world where our population and the health and care system are facing huge challenges. Cost of living crisis, increasing pressure on services and budget constraints in the NHS and local government. So evidence of what works to reduce health inequalities and provide value for money becomes more important. And then the question is, so what next? How are we going to keep the momentum and tackle inequalities in these increasingly difficult times? There is a present reality where people in the most deprived areas are dying 10 years younger and spending 20 more years of their life in ill health when we compare to people living in the most affluent areas. And then there is a future we want to create where our chances of living a long, happy, healthy life will not be determined by who we are, how we look, where we live, and how much we earn. That is going to require some magic. And in the past 5 years, I have seen that magic. I'm going to say we are that magic. We, the people working in Bradford District and Craven Health and Care Partnership. We have this responsibility to keep the flame burning and act as the conscience of our system. COVID-19 showed us the mirror and we saw the inequalities right in front of us, killing our people, our friends, and our loved ones. COVID-19 taught us a lesson, and we must not forget that lesson. We must work together, and the time to do that is now. And how can we not do that? Are we willing to accept that it is okay for a child to die because of mold in his house, and an elderly person to become ill because he does not have the means to keep his house warm? Can we accept that a mother will have different experience and lose her baby because of the color of her skin, and a child born in Manningham or Keighley will not be able to reach his full potential because of poverty, trauma, lack of education, and safe environment, and that this will continue from generation to generation? Will we accept that our people in deprived, multi-ethnic, multilingual neighborhoods of inner city Bradford and Keighley and people in rural areas of Craven will have different experience when it comes to access and outcomes of healthcare? And this is not just about morality or ethics. There is as much financial case to tackle health inequalities as there is ethical and moral case. Professor Michael Marmot's work calculated the treatment costs of health inequalities to be in the region of 6 billion a year. Productivity losses in the economy due to health inequalities amount to 33 billion, and a further 32 billion is spent on higher welfare payments. We spend billions of pounds on late cancer diagnosis, cost of prescribing to treat long-term conditions that are really more prevalent in deprived areas, and unplanned admissions as a result of complications of these long-term conditions, and they stem from the wider health and social inequalities. If in NHS we want to balance our books and stop the system getting into financial deficits year after year, we must tackle these health inequalities. So what can we do? So first and most important thing is not to lose hope and to have firm belief in our abilities. These are difficult times, and difficult times create strong leaders. And true leadership blossoms when times are tough. We are not some insignificant part in a big system. We are the system. We can and we will make a difference. Then there is the power of I, the I of inequality. What can I do in my role to tackle inequalities? We need to reflect and develop ourselves, develop our awareness of inequalities, and take action that is within our sphere of control. So we can embed this in our day-to-day work. To have a meaningful impact on health inequalities, we need to work on many fronts. We need to bring more and more people to this cause by using our circle of influence, develop networks and relationships, and support each other. We need to continue to advocate for equity-based funding and to bring more resources into areas of deprivation. But we also need to review and improve our priorities and our pathways of care. We shall make the biggest difference when we shall start to think about inequalities at every stage of service development and delivery, making it business as usual and not just an optional extra. We need to come together and take collective coordinated action to tackle inequalities across Bradford District and Craven. We must align all our efforts, totality of our resources, and our accountability and governance mechanisms to improve population health and reduce inequalities so we can truly plan, design, and deliver our services based on population needs and invest in frontline workforce in prevention and in communities. For that purpose, we developed Reducing Inequalities Alliance in Bradford District and Craven in 2022. The vision of this alliance is to harness the passion and equip every one of about 30,000 people working in our health and care system with the skills and abilities to tackle inequalities, and to create a movement that will transform the way we plan, design, and deliver our services. There are 4 strategic aims and work streams of the Reducing Inequalities Alliance. These are setting the strategic vision for reducing inequalities in health and the determinants of health, building the capacity in our workforce and leadership to reduce inequalities on many fronts, supporting best practice in the way we work, the skills we use, and the evidence we draw on to reduce inequalities, and facilitating space and time for evaluation and sharing learning from our approach. The Alliance is very well connected locally with public health, research, equality, diversity, and belonging, and the university. It is connected regionally with West Yorkshire Fellowships and Health Inequalities Academy, and nationally with the NHS England Healthcare Inequalities Directorate. So many of you are already part of this alliance, and I will really encourage everyone to sign up to the alliance membership. Sophie will be including the details in the chat about the alliance. So I'm going to finish by once again thanking all colleagues who worked tirelessly for this program and for the people of Bradford. When we launched RIC a few years ago, I finished that by the event with the words of Shams Tabriz, a 13th century Sufi mystic. Fret not where the way will take you. Just take your first step and the rest will follow. Don't go with the flow, be the flow. RIC was a milestone in our journey, but the journey goes on. Thank you very much. Sophie, I'm handing over to you and then Sasha, I think.
Yes, thanks, Sohail. So we're just going to show a quick video now before we hand over to Sasha. And it's just a new video that we've recently recorded, so it's completely brand new. No one else has seen it yet. And it just basically summarises the RIC programme learnings in themes. So there was some themes that came out of the programme that sat across a few different projects. And that's what we've based the events on this week. But as a bit of a summary snippet, we've got this video. So let me just share my screen with sound so you can all hear it.
Since 2019, the Reducing Inequalities in Communities program, or RIC, has led to 21 different projects supporting over 16,000 people across Bradford. Without the people and colleagues involved in delivering our projects, this wouldn't have been possible. I would like to say a heartfelt thank you to everyone involved. Over the past 5 years, we have learned a lot, and we would like to share with you some of our key messages.
Through RIC, we've seen that working closely with communities can help people understand and use the right services, helping them make informed decisions about their health. Our genetics project has been a positive example of co-design, involving the whole community to design training. Doing this made it clear that people needed a reminder of how the body works before being able to understand and discuss issues relating to genes and DNA. This shows us the importance of understanding people's health literacy when trying to tackle inequalities. Simply providing information isn't enough. We need to help people understand and use it too.
The RIC programme has allowed us to create community-based support for people with severe mental health issues, support which is integrated with existing services and supporting people to lead better lives. Examples are our Know Your Mind project and our culturally adapted therapies, providing tailored support for communities. Both services are delivered in partnership with the voluntary and community sector and our statutory providers, each of them bringing their expertise and knowledge, their cultural and language skills and their ability to understand intersectionality, all by a workforce that reflects our communities. We've reduced missed appointments, we've increased our engagement and shown reliable recovery for people accessing these services. The support provided is local, it's flexible and firmly based on the cultural and community strengths of people. These services are award-winning, but most importantly, we're supporting people we serve to have brighter futures.
When we support a person to change their behaviour for the better, we can help them live healthier for longer. But these lifestyle changes are hard to make and maintain. The Living Well Beep service supports and encourages people to increase their physical activity. And through RIC, we've been able to test out if having more contact points between advisors and service users encouraged them to stay on the programme. We saw big improvements in the RIC area, and as a result, we are changing the district-wide offer to include extra contact. To help people change their behaviour, we need to provide ongoing contact and support.
RIC has shown how important it is to take a holistic approach to a person's health, creating teams of different roles who work together to look at the whole picture of what is happening for them. Through the Proactive Care, Admiral Nursing and CLICS project, we've tested new service models based on multidisciplinary teams and shared care pathways, working across organisation boundaries. They have shown where patients are given personalised interventions over a number of appointments, we can reduce the need for reactive care. The Proactive Care team tell us that the best outcomes for patients are seen when professionals work, learn and engage together.
These are just a handful of learning from the RIC program. Our RIC report, which will be shared alongside this video, shares learning from all our projects and our program approach in more detail. Please take a look. When we collaborate together as one system, all working to act as one, we can make a difference. We can work towards reducing inequalities in Bradford District and Craven and achieve our vision of helping people live happy, healthy at home. Thank you very much for watching.
Sorry to anyone that was a bit sketchy for. I think it's because there's quite a lot of us in the meeting, isn't there, with cameras on, so apologies, but I will post that in the chat so that you're able to watch it in your own time, and please do share it. So I'm going to hand over now to Sasha. Sasha, I'll let you introduce yourself because again, you'll be able to do that better than me, but you're going to talk a little bit about commissioning and how you've woven the RIC projects that you've been working on into the wider mental health work that was already happening. So Sasha, I'll hand over to you.
Right. Thank you very much, Sophie, and thank you, Sohail, and welcome and good morning, everyone. It's lovely to be here. My name's Sasha Bhatt. I'm the Priority Director for Healthy Minds, which is our programme across our partnership for mental health, learning disabilities, neurodiversity and substance use. And yes, as Sophie said, the topic I was asked to speak to about was about our strategic commissioning, the approach that we took to taking on some RIC projects that had a mental health focus, but also how we've woven that into the work of our programme as a whole. And the journey always starts with people. It starts with the experiences of our communities and how they access our services and what we learn about them when they're accessing our services and what we see from our service performance data as commissioners about those services. And I can see there's a couple of people here from our quality team and you know, part of our commissioning team who would have definitely been involved in the How Are We Doing reports that we used to pull together. And on one of those reports, almost month on month, we would always say, yes, look at our talking therapies access rates and targets that are set to us by NHS England, and we're not meeting those. And how do we meet those, particularly for the population in city, and having a CCG, a clinical commissioning group that was focused on that population, really put a spotlight on the access and the treatment that people were receiving of that service. So that was definitely an area of inequality that we knew about. And so when we think about the inequalities that we all talk about the inequalities about poverty, of social economic status. But I think the approach that we took was very much about what are the inequalities we know about the services that we provide, and what do we know from people's perspective, what do we know from our service perspective. So we took a range of those topics, and together through our mental health partnership that we had at the time, talked about what are the things that we would do to address these. And we had a series of ideas, which then we used that Delphi process to pitch forward some of those ideas. And we were quite lucky that 5 of the 6 ideas that we put forward were accepted to be part of the RIC scheme, and we were very keen to include them in the RIC scheme. And that there was several layers to this, because when we talk about our inequalities across our district and that people access, we know that within those inequalities there are inequalities, and people who have mental health, serious mental illness, experience some of the highest inequalities in our district. So if you look at our cardiovascular data, if you look at our respiratory data, our MSK data, and you look at and you put the lens of somebody who has serious mental illness accessing those services, you'll just see how much of an outlier they are in those services. So it's not just about the mental health support that those people receive. So we made a really conscious decision to be a very active, proactive, loud member of the RIC partnership from the outset, to lobby for the resources that we wanted to see for mental health, use the evidence, use the information, use the insight that we had about those inequalities to make those cases, and the co-production. And I know sometimes we use that word in a very jargonistic lens now, but use that sense of the partnership, the people that insight brings together, because everybody's passionate about the things that they know. How do you bring that passion together and hear the ideas? And those were the ideas that then came forward for discussion. So we had a really clear remit as to what we wanted to do and what we were going to do. We were really clear about our level of influence that we could have, and we absolutely exploited that level of influence in terms of making sure that we could make those cases. So that was very much about just setting the outset. When you look at and you see the RIC programme of its life journey approach, that very much mirrored the life journey approach we were taking in within mental health services, about looking at how do we create services that are not about the problem only, but are really about people's lives. And again, like I said, that came from people's stories. So when you look at the range of projects that we had for mental health, and I'll just list some of those. We had a project called Future Focus, which is a project for people who experience psychosis. And we know the data around psychosis in our district. What this project looked to do was, rather than, we've got the services for psychosis in our district, but what about the families of people? Let's understand, and through that data, we really looked at working with families, working with wider siblings, and that whole family approach. That whole family approach was really important in city, and that's what we heard from people in the district about multi-generational families, about families living together and being carers, not being the known carers that we sometimes hear about, not recognising the term carers, but looking after their families, looking after children, looking after grandparents, parents with serious mental illness, and how we made sure that that support was wrapped around listening to the GPs in terms of what they saw in their clinics, in the 10 minutes that they have that they can't address and support. What does that look like? So it was building a picture of all of that together. The second project that we had was very much about children, young people, and we started our first initial inset was really thinking about children in the city area who are in school. How do we make sure they've got the right cultural adapted support and support that provides them to thrive and make the most of those school opportunities. But what we heard very much from parents is children start on a poor footing because some of that trauma, some of the incidences that happen in their life happen in that 0 to 6 period, and we needed to do a lot more in that 0 to 6 period. So we used some of our RIC initiatives to boost what we could do in that 0 to 6 period, both by working in partnership with Better Start Bradford on Little Minds Matter and expanding that element, but also growing an element that we had within Bradford District Care Trust, which is the Special Educational Attachment Development Service, and that now has, through this process, become one of three areas of leading excellence in the country, across both England, Scotland, and Wales. So it really taking things to the forefront. I mentioned earlier the Quality Committee and the Quality Committee hearing month on month for a couple of years, if not longer than that, about poor access to talking therapies. So that was a project then we took on with our university, with our statutory partners, with our university partner, and with voluntary and community sector to really think about how do we adapt those services. That project in itself now has gone on to be an award-winning service. It's really changed the way that we are delivering support. It's boosted the way that the team works as a whole. They've seen their appointments for people in that population who previously would, and then this was the feedback again that we would get, is people aren't accessing this service. When they do access it, they drop out very quickly. So those two things directly were absolutely changed by providing that adaptation to that service that meets people's needs. And we see now appointments completed and a reliable recovery at the end of that. And we've got one of the best reliable recovery rates now for that service in the country. So hardwiring our work into our general work was about working from what our purpose is, and our purpose was always to improve the mental well-being and mental health of people in our district and understanding their inequalities. So that element of hardwiring into our system has been quite easy to do because it was always what we wanted to do. It was about testing out ways of working, and I think for the majority of our projects, all of those have worked. They've been things that have tested, they've worked, we've implemented, and we've grown as well. The children, young people's one, it's absolutely changed how we work in terms of our services. We previously had our voluntary community sector services delivering children's support separately to how our CAMS and our specialist services deliver. What we demonstrated through the RIC programme was how you can bring together your primary care, secondary care, voluntary community and your social care services together to really work around a family and provide that support and provide that access to not just the individual who comes forward with the problems and that's who you see, but really understanding the causes behind that and how do you support a whole family who also might be accessing services and accessing different needs or not being able to express their needs. Throughout this, one of the things that we did learn, and Sohail mentioned we were mobilising some of these services through COVID, was that we didn't always have the workforce for the types of services that we wanted, and that was something that we really wanted to think about. How do we start to address people understanding our workforce and understanding their roots into that workforce. And so the apprentice scheme that we started was very much about being that avenue and that pathway into services. And we're now in the fourth cohort, 6 people each year coming through that programme who become part of our services, help engage with communities further, build that insight, provide that feedback and challenge into our boards, into our groups, into our commissioning practices, and also for themselves that they build their skills and their CV and have gone on to either continue to be part of the programmes or to work in our wellbeing hubs or other parts of our health and care partnership or onto further education. So a few of them have gone on to university as well. So real pathways to employment and to progression. And again, thinking about what do inequalities mean? That they are those aspects of social economic disadvantage that people have. So how do we help through the work that we do proactively and very explicitly say that we will support people to access employment and to be part of the types of services that we are now creating. So a lot of the voluntary and community sector partners will use people with lived experience, people from our communities who are delivering those services. And that's been the principles and the ethos. It's been always a constant conversation, dialogue within our groups, that we have a provider forum that's set up. We have communities of practice. They all come together to talk about how they are addressing these needs together and how we can work together. And yes, there's always things we could do more of. There's things that we could learn more about. And that is the process. That is the constant process of us working together. And I think if I were to do this once again differently, and we had another windfall of money that came through from NHS England, because those, as Sohail said, those statistics will take quite some time to change. I think the one thing I would do differently is probably approach the number of projects that we did differently. I probably would have chosen 2 or 3 rather than 5 or 6. And really focused further. But that focus now, I think we could probably only do that because we've been through this journey so far, and you learn and build from that. I'm going to stop there because I could talk for the whole day about each of our projects. And I think we are talking again later about the culturally adapted therapy, so you'll learn a bit more about that particular project. So I'll stop there because I think we've got about 15 minutes and it'll be great to have questions, because I think a lot more comes through the dialogue and talking to people. So I'll stop there.
Thank you, Sasha. That's really good. And yeah, just to mention, there is a session this afternoon where we will be talking in a little bit more detail about the projects. We can't cover them all in the Learning Week. That's why we've gone for themes, but I do encourage you to sign up to the other sessions if you haven't, and I'll post that link in the chat as well. Sorry, there's lots of links. So we'll do questions now. We don't have loads of time, so Sohail and Sasha, if you could keep your answers quite concise, that would be great. I'm going to work upwards. I can just see a comment from Carlton, which I think is really important to be remembered, is we started the RIC projects, didn't we? And then COVID-19 happened, which made things very difficult. And the projects were really good in being flexible and adapting to those. And then obviously now we've got the cost of living crisis. So I think that's important to remember. Scrolling up, yeah, all the information will be shared for those who can't attend. So another question from Carlton: is there an ambition in Bradford District and Craven to continue the great strides made in co-producing future projects? And there is a session on co-production, just to say so. Sohail or Sasha, either of you like to answer that one?
Yeah, I mean that is the major, main learning from the RIC, the co-production with communities, providers, commissioners, all colleagues coming together, acting as one. So yeah, that is very much now almost a norm. It's becoming a norm in Bradford District and Craven. But yeah, we can do more, especially with learning from our communities, such as listening in sessions. They're brilliant. So we can do more, and we are doing that. I think Jill, want to add something?
I'm Jill. I'm from Better Start Bradford, and I did a presentation to a conference last week about the Little Minds Matter project, and I think one of the things they were very interested in was the way that the sectors work together so effectively. And I think, you know, I'm really glad that you mentioned that, Sasha, in the presentation, because I think it's really important. And for me, I really don't want us to lose that when the RIC goes. RIC has been a sort of trailblazer in making that possible. And it's, from our point of view, it's a really important sort of step forward. And, you know, I think it's always challenging for the NHS to do that particularly, but, you know, we've done it. And so let's not lose it. Really important to keep doing that. Absolutely, Jill. I think there's that learning that we have about how well we do work together when we work together and what we can achieve. And while sometimes I think, you know, we all look back on COVID and think that that was a disaster that happened, one of the things that it did do, it really did bring us together really quickly. And I think having to mobilise during that period, made, I think, definitely the teams that I were working with and who were mobilising just really conscious of how important the work that they were doing was, because that was the inequalities work, and we were seeing that really highlighted around us. So it gave probably 10 times boost to everyone to do what they needed to do, because it was so they saw the importance of that and the relevance of their work to what was happening around them, both for staff and the people who were accessing their services. And then I think the other aspect about that working together is how the systems that we have are enabling that to support. And I think we still have a bit of a journey to go on some of that system working, but the way that definitely teams try to co-locate together, they communicate, you see them working together, you see them knowing each other and understanding their patch. And that was really visible around the city area, that people know each other in the city area. They know who to speak to, they know who to go to for a service, and they know how to enable access for somebody. And that some of those things you can't really capture in your reports and the way that we talk about the work, but they were absolute gems of delivery throughout this.
Thank you, Sasha. A quick question from Rachel. I think you've kind of answered it actually in the chat, Sohail, but I don't know if you wanted to add anything else, just in case people can't see the chat. Rachel was asking, what were the challenges in taking a partnership approach to tackling inequalities? Is there anything you wanted to add there? And then we'll go to Sasha if you've got anything as well.
Yeah, well, I think obviously partnership working, as I said, traditional ways of working is, you know, very much commissioning and provision in silos and you know, academic research at one side. So partnership working, a new thing brings, you know, some unknowns. But as Sasha said, that's the main thing, is that what we did in RIC and what we should be doing is to spend time together, really defining why we are doing what we are doing, essentially. And as Sasha said, you know, everyone was working really hard because they could see they were working for inequalities. They were working for people who are really living in the deprived area. So starting with why is really important. Obviously, when a lot of people are coming together, there will always be issues around the, you know, what to prioritize, how to prioritize. So spending time defining the principles of how we work together, the prioritization frameworks that we will be sticking, you know, along as we go along was really important. And just keep reminding ourselves that our purpose is bigger than any of us. In RIC, the population health management approach helped. You know, it was really data-led, intelligence-led, working with the communities, bringing everyone on one page. Delphi process was really important. So there are a lot of things from the RIC learning that definitely RIC as a program. Yes, there was funding, etc. But the learning we just have to incorporate in our day-to-day how we do things here. That would be the main thing from RIC.
I think for me, one of the challenges, and we often always talk about challenges, then we always point to another area and say, oh, we had challenges in in data, or we had challenges in this. And I think there were internal challenges. One of the things that we definitely had to do was first to unlearn some of the things that we've always used. So definitely in the first part of COVID, we did a lot of time spending about our language and our use of language, and what we might need to unlearn through that. We needed to undo some of the ways that our services delivered some of their practices, and actually had to take that internal view to say we will stop doing things in this way, or we need to make sure this is the approach that we take, or this is a service that we need to stop. And we did make some of those difficult decisions. So that, and sometimes that, when you make those difficult decisions, that can affect your partnership working, because partnership's great when everything's going great, but when you do start to make difficult decisions, that's when your partnership really comes to test. And the other aspect is, even within the clinical commissioning group at the time, like I said earlier, we were quite loud about mental health, and that's because it felt that mental health was seen separately. And so it's one of the things that definitely this RIC programme has brought on is just the importance of mental health in all our work. And we've definitely seen that shift start to happen, about seeing mental health as part of all of our projects and the way that we work, and well-being and mental health being part of our approach. So those were some of the challenges that we set out, but really set out with that approach of how do we work together, how do we build together, and having people round that table who really were open to listening and open to the table getting bigger and bigger. And it did, at one point we used to have like 30 people in the room, and saying in the virtual room. But even in 2019, when we were planning this, we had a huge room of people coming together to help mobilize this, and that energy really was sustained through communication, and Sophie, yourself, and the team that have been there around the comms for this programme have really helped keep that message being shared with providers, between providers, within the organisation. That's been really important. And those previously had probably been challenges that it would have stayed as a quiet project that Sohail's team over there are doing, but actually the way that your team have helped really support that dialogue in the organisation and in our partnership as a whole, I think has really helped us put Reducing Inequalities Alliance on the map for the country, not just for our district.
Thank you, Sasha. I've got another question from Carlton, and then we might have a time for one more, just because I'm aware of time. So Carlton has said, how much of the RIC work is likely to be mainstreamed or at least extended in the areas of high need and where prevention or health creation work is most needed?
Yeah, so I think that there are a couple of things. One thing about the RIC funding, and obviously that is with the program boards, and they are looking into it. And as I said, there are financial challenges, but what we really need to ensure, and this is my learning for the past 5 years, that we really need to start looking at, as I said, the way we design, we plan and design services, and the way we mobilize the mainstream funding. These sort of fundings are for testing approaches, as we have tested RIC approach, and now this learning, that would be the main thing to incorporate. And if I look at people like, for example, Sasha, incorporating all that into the way mental health services are provided, a lot of other initiatives are now, like well-being hubs, and it's just we just need to make sure that inequalities is part of our commissioning, is part of our planning and designing process. In terms of funding continuation, that decision is being made with the program leads, and we will be communicating it. The program leads will be communicating soon to the projects.
Thank you, Sohail. Does anyone have one last quick question? If not, we'll let you go a couple of minutes early. Just stick your hand up if you do. What I've done is I've just posted in the chat the session that we've got this afternoon. So that one is seeing the whole picture, working together to provide holistic care. So we've got colleagues joining us from the Proactive Care Team project, and then Sasha's joining us to talk about culturally adapted behaviour. You can help me here, Sasha, because I'm really bad at acronyms. The CABAT
Culturally
service.
adapted behavioural activation therapy, but
That's it.
culturally adapted therapies for short.
You just get used to calling it CABAT. So that's this afternoon. There is still spaces if people want to join. So I've put that link in the chat for you. I think that's it then. It doesn't look like there's any more questions coming through. I don't know if you want to wrap it up, Sohail, and we'll see anyone else at the events for the rest of the week.
Well, as I said before, just want to say, real thank you. Thank you very much for being part of RIC. And thank you very much for working in this in Bradford District and Craven and working for the people of Bradford. And there is so much passion in Bradford District and Craven. And as I said, let's just keep hope and let's just work together. And we can do it. And we will do it. So thank you very much. Just want to say real big thank you.
Thanks,
Bye-bye.
everyone. Bye now.
Everyone, bye.
Bye.
Bye.